Tonight, as y'all saw, this lecture is like 15 slides. It's pretty short, pretty simple. So if I was studying, I'd probably think, there's probably not a ton of content on this section.
We like that about you.
There is gonna be some, so don't not study it. But you would prioritize in other areas. The rest of the night's gonna be review. We're gonna review over content, do a couple different things from there. And that's what we're gonna do for the night, okay?
You're really good.
Yeah. She sells them pretty well. I'm at the hospital buys them. So we're gonna talk about advanced emergencies, part 2 tonight. Meredith, were you able to find the PowerPoint? Okay, perfect. Shouldn't have done that all at one time. So we're gonna talk about MODS, or multiple organ dysfunction syndrome, but it's MODS for short. And then we're gonna talk about epiglottitis as well. And that's gonna finish off your emergency content for the semester. This is all the content that you're ever gonna learn in nursing school. Everything else is pretty much review in 5th semester. There's like professionalism, how to sign up for your NCLEX, legal ethical practices, that might be some newer content for you. But for the most part, like body systems, that kind of stuff, you're gonna learn everything you already need to know tonight, okay? So y'all are almost there.
That's really great.
So get excited about that, okay? So when I talk about MODS, or multiple organ dysfunction syndrome, I'm really talking about the failure of the more than 2 organs. 2 or more organs are going to fail at some point. So progressive organ dysfunction in 2 or more organs as a result of cellular damage and massive release of toxic metabolites and enzymes. One of the big ones is gonna be your lactic acid, and we're gonna track that as part of our MODS treatment plan. But in general, toxic metabolites and enzymes. This can be super progressive, super quick, very dangerous if we don't treat this and assess this, diagnose this early. It can lead to a high mortality rate pretty quickly. Common causes: shock, any type of shock. We're gonna talk about shock in just a minute and just kind of review over that. Some type of trauma. Sepsis is in red because that's the big one. The main root cause is some type of infection response. We have some type of infection, and then our immune system responds to that infection, causes an overwhelming amount of immune system response and inflammation response. And that causes this organ dysfunction to occur. So you may see it as septic organ dysfunction or multiple organ dysfunction syndrome, because they're very close, very similar in nature and how they work. The pathophysiology is very similar in how they work, okay? As we're defining MODS, we have primary versus secondary MODS. So with primary MODS, we have well-defined insult, so some type of insult, so whether it be direct trauma to a specific organ. So that dysfunction occurs very early, and that result of that dysfunction is the regular result of that primary disorder, that primary dysfunction. That's gonna make a little more sense in just a second. Secondary MODS is widespread, sustained systemic inflammation that results in dysfunction of that organ, not related to the primary injury. Okay? So I get trauma. That causes dysfunction to 2 primary organs. But then I get infection from that trauma, And that causes that secondary MODS to occur, that inflammation and that systemic infection to occur. So secondary, not related to that direct insult, that initial response. It's an after effect of the initial response. That's what your secondary MODS is. Let's talk about a few numbers. Not gonna test you on numbers, but just to see how critical this truly is. Up to 50% of cases in the critical care unit has some type of MODS related response. Mortality is ranging from 44 to over 60 or 76%. It really depends on how many organs are dysfunctioning, are not working appropriately. There's a 100% mortality rate with 7+ organ failures, okay? So you have more than 7 organs, you're gonna die, basically, is what it's referring to. So it's pretty serious. Like I said, one of the main causes is shock. So let's review shock real quick. I've got cardiogenic. When I talk about cardiogenic shock, that is direct pump failure. My heart is failing for some reason or another. It's not fluid related. It's direct insult, direct injury to the heart itself. All right? Can someone tell me a common cause? What's a direct insult to the heart? Direct injury to the heart?
Heart attack.
Heart attack, good. MI, what else?
Stroke.
Stroke to the heart?
No.
No, okay. What about cardiac arrest? Direct insult, right? CHF, could be one. Yep. Valve issues, dysrhythmias, that kind of stuff, all right? So remember, just direct injury, something that's causing the heart to not pump as efficiently as it should. Just decreasing that perfusion. Neurogenic shock. That's pretty self-explanatory. Spinal cord injury, right? With septic, we have that infectious agent, some type of bacteria that overwhelms our immune system, puts our immune system in overdrive, and causes an overwhelming inflammatory response, which overall decreases that perfusion. Now with hypovolemic, this one's going to be a little bit different than your cardiogenic. Now I don't have enough volume on board. My heart might be pumping efficiently like it should, but it doesn't have adequate volume to perfuse like it needs to. So overall, my total body volume, my fluid volume is decreased, causing this hypovolemic shock state. So what are some common causes for that? Burns, hemorrhage, trauma, surgery, maybe some GI bleed, then I can lose a lot through my stool. Then we have distributive shock. What's that?
Anaphylactic shock.
Not quite. So my fluids are distributed elsewhere, if you want to think about it like that. Instead of my total body volume, my fluid volume, being in the vasculature space, it's now in the extracellular space, so I'm third spacing. In that instance, my body volume, my fluid volume, could be normal or it could be increased. It's just not within the vasculature, and that's what's decreasing my perfusion overall, why I'm not perfusing.
Lateral cascade would be like an efficient.
Yeah, you could. So things like pain, stress, spinal cord injuries, septic shock could also lead to distributive shock. My capillary or my vasculature permeability, anything that's going to affect that, causing those leaks to the extracellular space. So where my volume is leaking out of my vasculature area, anything that's going to cause that is going to contribute to my distributive shock. And then I have obstructive shock. So not directly related to the failure of my heart, but it is related to my heart, the non-cardiac factors, things that are not directly related to my heart. So like coronary artery disease, tumors, maybe I have an increased intrathoracic pressure, causing increased pressure inside that chest cavity, pushing on that heart, not allowing that heart to fully expand, fully getting that good blood volume so when those ventricles beat, it perfuses and pushes that blood forward. Not able to do that. Maybe I have some stenosis in my vessels, so as my heart is beating, it's trying to beat extra hard to push that blood forward, but it's not able to because of that narrowing of that artery, narrowing of that vessel. So shock is going to play a major role in MODS. So let's talk about the pathophysiology of MODS. So either some type of infectious agent or something like one of these shocks back here causes the initial trigger of this response, of this flow chart, if you will, of this cascade. With that infectious or non-infectious trigger, that's what's going to cause a localized inflammatory response at this point. You're really not going to see it system-wide. As it's unchecked, and we may not initially diagnose it on this stage, that's when it becomes unchecked and it really starts to get big. The dysregulation of that inflammation response. This is where we're going to see the systemic effects of that inflammation. Then we can go two different routes. So if you remember when we're talking about cellular metabolism in, we'll say, septic shock, for instance, and we switch from aerobic to anaerobic respirations, remember that builds up all that lactic acid. And so our mitochondrial dysfunction right here, that's what it's referring to. My cellular metabolism is not able to keep up, not meet the demands of the body. So I'm switching from aerobic to anaerobic respirations, causing the lactic acid levels to increase, causing that acidosis to occur. As that builds up, that overwhelms my system, and then that causes organ dysfunction or organ failure. Remember, MODS is 2 or more organs that fail. If I just have one organ, I just have one organ failing. But once I get to that 2 mark, that's when it starts to get a little more serious. I can also go the other route here for endothelial changes. So increased vascular permeability. So I can start the third space. My vessels tend to start leaking. I have all that swelling, all that edema. So pretty much all of y'all have seen that at this point. You've had that testicular edema where they have the huge testicles, like cantaloupe size. Their arms are real big. You just have to put them on the Chuck's pads because they're basically leaking, edematous, all that drainage that's occurring. That's where this comes into play. And because of all that third spacing and all that extra volume that's not in my vasculature space at that point, that's why I have that tissue hypoperfusion, decreased perfusion of my major arteries, my major organs. I'm not able to deliver that oxygenated blood like I should, and that's what causes that organ dysfunction there. Another endothelial change in the vasculature space is the increased risk or chances of a thrombi to occur, so a clot to occur, especially in the small little peripheral arterial vessels, the real tiny ones. So this is a really tiny clot that's going to occur. And as it's perfusing out, it's clogging up those arteries, not allowing for that good oxygenated blood to get where it needs to and perfuse and oxygenate those vital organs, those peripheral fingers, toes, that kind of stuff, causing tissue hypoperfusion, elevated lactic acid levels, and then organ failure. This is a big chart, but this is basically the breakdown, the patho of how MODS occurs in the body. You already know this type of stuff already. It's just putting it in this chart. You don't think you know it, but you already do. We've learned a lot about this already. Some type of inflammation, infection occurs. Our body tends to respond to it, and then our body can't keep up with that response. So it just gives up, basically. Decreased tissue perfusion, organ failure. Real simple breakdown there, okay? I think on the one that I posted, the slides are backwards. So go to the next slide, and then you'll go back one. So flip your page over. Yeah, there you go. I noticed it today when I was preparing. There's a couple different ways to measure the severity of your MODS. To measure severity, the chances of organs failing, and the chances of mortality rates, overall ICU stays, how this is going to affect my body overall. And as I'm measuring that, I got 3 different ones here. There's several out here, but the main ones is your MODS score, your SOFA score, and then your logistic organ dysfunction score. The main 2 we really look at is the top 2 right here. So your multiple organ dysfunction syndrome score and your sequential organ failure assessment score. This one as well is really related to sepsis too, and you'll see that. Overall, in general though, we're really looking at how the different type of organs are functioning properly. So when you break it down by body system, it makes a little bit more sense. So cardiovascular wise, I'm looking at my heart rate, I'm looking at my MAP, I'm looking at my CVP to determine if my cardiac cycle, my cardiovascular system is keeping up to the demands of the body like it should. Respiratory system, how can I tell if I'm oxygenating appropriately? SpO2, blood gases. Blood gases are going to play an important role in it. I'm going to look at what's called the PF ratio. You remember that? The PO2 over the FiO2 ratio. So I get a blood gas, determine how much my PO2 is. That's the one that can go up above 100. It can go 400, 500, 600 if you want to. And then I compare it to how much pure oxygen I'm on. And then if I look at my kidneys, what kind of things should I look at to see if my kidneys are working like they should? Urine output, that's the easiest one, right? But I can also look at my BUN, I can also look at my creatinine as well. Sometimes we'll look at our GFR to see how adequate my kidneys are filtering as they should. Neuro-wise, most of the time I'm going to get a GCS score, the Glasgow Coma score, to assess my neurofunction, but I can also do some further neuro assessment things, just basic bedside neuro assessment. Check my altered mental status, my level of consciousness, to check my neuro system. And then I can also check something like my hematologic system. So my platelets, my blood count levels, see if they are where they need to be. My clotting factors, my clotting times, my PTT, those as well. So that's what these 3 different scores are going to assess overall. So here is a chart for your MODS and to measure your severity. A score of 0 is your lowest score you can score. With a score of 0, your ICU mortality rate is basically 0%. You're gonna have a very quick short-term stay. So if you were a patient trying to bet on your life, you really want a lower end score when you're looking at this chart. And that makes sense. So if I look at my respiratory, for instance, PO2 versus my FiO2, my PF ratio, if it's greater than 300, I'm oxygenating like I should. My PO2 is super high, and I'm not demanding a whole lot of FiO2 to be on board to get my PO2 to that level. Other things, my creatinine is doing pretty fine. Neuro assessment, my Glasgow Coma score is at 15, which means I'm doing okay. As your points increase, the more severe you can get. All right, so I got 4 as my top score, and then I've got 6 things right here. So 24 can be my max there. Your 21 to 24 points, 100% mortality rate if you're getting to that point. So you can kind of calculate it in between, and I have all the numbers if you want them. I'm not going to test you on that, but it's good to see these charts. Okay? You're going to get exposed to these if you start working in the critical care area. All right, your SOFA score. Remember, this is very septic related. The higher the number, the higher the score I get, means that I'm at a higher risk for MODS or organ dysfunction. Usually 0 to 6 rate is going to be on the lower end for mortality rate. And then when you get to 15 plus, greater than 80% mortality rate with this one. Again, this looks very closely to the other one. They measure roughly the same thing. Respiratory system is your PF ratio. We're looking at coag panels here. I got my GCS score again. Cardiovascular is the only one that's a little bit different. Here I'm looking at my MAP, and if I'm using other drugs to get my MAP, to achieve my MAP of greater than 70, because they want a little bit higher for this one. But I'm also still looking at my creatinine and my urine output for renal system. Like I said, overall, these scores are looking if my organs are working like they should. So when you think about an organ, think about the things that I can assess for, look at to make sure that my organ is working appropriately, functioning appropriately like it should, okay? And this is the last one. This is a lot to read, so we're not going to read a whole lot about it. Don't really care about it, honestly, okay? Don't look at it.
How often are you doing these schools?
At least once a shift, but more frequently with any changes. And then they'll get lab works every 4 to 6 hours as well. If you're doing a septic workup, they're gonna get those 30 mils per pigs of usually like normal saline into you as quick as possible. You're gonna get a lactic acid score. If your lactic acid's below or above 2, I believe it is, at East Alabama, you have to check it again within a certain time frame, and then you go from there. But it's really hospital specific. So, and then you gotta get your antibiotics on board. You gotta do all the other things to treat whatever they're there for as well. So, what's up?
Does, like, if they draw those labs every 4 hours, and does it populate into a score automatically, like in your software, like in Cerner, or you have to like sit down and get your
Yeah.
little card out and?
Usually you're not the one that's doing all that.
Okay.
You're just looking
That's
at
good to
like,
know.
oh, beginning creatinine, yeah, that's pretty bad. My kidneys are not doing what they should. My lactic acid levels are going up, so I know I need to get more fluids or get something else on board. My blood pressure's off, so I need to fix the problems that are arising. Usually the physician is gonna start doing these SOFA scores, your MOD scores like that, and kind of considering what things are happening. Some hospital softwares will have a built-in SOFA score that you chart, and it'll give you a reading at the end. So you won't have to calculate the numbers itself. I don't believe Cerner at East Alabama has it yet. I know they have like a GCS score that you can do. They have an NIHS stroke scale score that you can chart in, but for now, I don't believe they have a MOD score or a SOFA score. They have little printout cards that you can look at for reference, but.
Do you have those sepsis scores, like the RRT, it'll say
Yeah.
their lactic's high and like if their blood pressure or whatever, and that's when you let them know to.
Right, so it like populates a screen up. says, RRT alert, your values are off or indicating, sepsis. Look at it a little bit further, assess a little bit more, let somebody else know, let a physician know, so they can look at it and begin that septic workup. Because we don't wanna catch this too late, cause if we start getting past a certain point within this, algorithm right here, there's a point of no return at that point. So you're trying to catch it early, treat it early, before it becomes a more of an emergent type of situation. So,
They use that to decide whether to prone them out or not. Like this score's the highest, they're gonna die if we don't prone them.
so proning is gonna be a little bit different. Proning is not directly related to MONS, it's more of a respiratory system failure, which could be contributing to the MONS. So they kind of can correlate together. For East Alabama, the criteria for it is the PF ratio. So we do assess the PF ratio in our MODS workup, which is one of these right here. So if we're in the less than 150 range, that's typically when we start considering proning. But you also have to look at other factors when you're thinking about proning. Size of the patient, if they've had recent surgeries, but sometimes it's kind of a last ditch effort to see. Once they start getting their PF ratio below this, you're gonna start to see other organs fail because of the inadequate oxygenation, ventilation, and inadequate perfusion as well. So, not related, but related at the same time. Okay. Any more questions? Nope. Okay. I put the Glasgow Coma score back in here as well. I know it's in your advanced part 1, but since we've been talking about GCS a few times, just throwing that out there again. So I have mild, moderate, and severe on my GCS score. Anybody tell me the reference range for mild? It's 13 to what? 13 to what? You said 16? 15, 13, 15, I like that, I'll take that answer. What about moderate? None of y'all studied, that's okay. Moderate, it's gotta be less than 13, right? So 9 to 12, there you go, okay? So moderate's 9 to 12, and then severe.
Anything less than 8.
Less than 8, so 3 to 8. You can't get a 0 on this. So you have no response, and no response. Minimal score you can get is a 3. So again, mild, 13 to 15. So overall, you're doing pretty well neuro-wise. 15, you're pretty much awake, following commands, alert and oriented, that kind of stuff. So mild, 13 to 15. Moderate, we're starting to see a decline. Moderate's 9 to 12. And then severe is 3 to 8. If I begin to fluctuate between those values, I need to let somebody know. So if I initially go in and get a GCS score of, let's say 14, 2 hours later I walk back into my patient's room to do something, I notice that there's a change in their LOC, which is really the first indicator of something neuro happening, that change in LOC. I do another GCS score, and now it's 9. That's a pretty big impact, right? Now I move from my mild to my moderate GCS score. Let's let that physician know, maybe I need to do a further workup. Maybe I need to get a CT scan, an MRI, something like that, just to confirm nothing else is going on, okay? That makes sense? All right. You taking notes for your in-class? You ready? Okay. All right.
She's got this.
This is, yeah, you really do. You're more prepared than you think you are, I promise. This slide right here is a lot to it, I know, but it breaks it down by organ dysfunction. So if my cardiovascular system is impaired, these are the types of things that I'm going to see be affected. So decrease SVR, my systemic vascular resistance, all right? Decrease in my right atrial pressure or your CVP, remember they're the same thing. Decreased cardiac output and cardiac output index. Remember, I'm having decreased perfusion overall. My volume, my intracellular volume is off. My blood pressure is decreasing. because my heart's not pumping like it should. So I'm gonna see those changes. I'm going to expect those types of changes. That makes sense. Other things like pulmonary, dyspnea, shortness of breath. I'm gonna have a decreased O2 or some type of abnormal O2 overall. That makes sense because my respiratory system is not functioning like it should. All right? So it's a pretty big chart, but I would kind of have a general idea of how each system is going to be affected and how you would assess that system. I'm not going to read it all to you, but this is a good slide. Okay. Now, medical management wise, for mods, it's really specific on the major cause of the issue. So if it's infectious in nature, I gotta deal with that infection first, and then I have to provide support for whatever organ dysfunction that I may have. Same with the non-infectious side. If it's some type of shock, I gotta fix that shock, and then I have to provide supportive care for whatever organ is dysfunctional. Yes?
So, you remember when you said it's like a certain order of the organs or something of what's important, what's not important? You remember? Like the heart and then the brain or something like that?
Don't know that.
Well, anyway.
I can't remember what I ate for breakfast yesterday. So.
Are you going to treat whichever organ is most important first, I guess?
Or
does it not matter?
Really, you can't live without your heart, you can't live without your lungs, you can probably live without your kidneys.
That's what I'm just
So,
saying.
Yeah.
Order.
The important organs.
Thank you.
Gallbladder, don't really need that, right?
Take it out.
It's more of your ABCs, airway, breathing, circulation, keeping those in check. So again, it determines your treatment plan is dependent on what is malfunctioning. So you have to have a thorough understanding of the patho behind mods and the patho behind what is causing the issue, the injury, the insult in the first place. First things first though, preventative strategies. The number one cause is septic shock, which is infectious. So infection strategies, infection prevention strategies. Overall, my fluid volume, what is the status of my fluid volume? That's gonna be important. If I need more fluid on board or I need to take excess fluid off to help with perfusion. If I'm receiving too much fluid, that could cause an increased edema, mess up my vascular permeability, and cause that edema. The big one to focus on for medical management though is gonna be this third bullet point, organ perfusion, organ support. So if I'm helping out with my cardiovascular support, what kind of intervention can I do to help my heart out? To get my heart to break or to help my heart beat a little bit better, help it perfuse a little bit better? What do you think? Sam, you're CD, you should know these things.
You can do a balloon pump.
Balloon pump, good, right? Does a balloon pump help out with my heart? It's giving my heart a break, helping it through this kind of troublesome time, this dysfunction. So it's helping with that perfusion. And then in a couple of days, when my values go up, so my heart rate, my CVP, my blood pressure begin to stabilize out after I've treated this infection or other injury, insult that's causing this, then I can reevaluate, potentially take out that balloon pump. I can also do a VAD or ventricular assist device as well. That helps out that ventricle perfuse. So as that ventricle beats, it's gonna help that blood circulation.
Is that impelling?
Real close to the impeller. Yeah. So that ventricular assist device kind of looks like a boat propeller almost in there, and it kind of spins around. As that ventricle beats, it spins, pushing that blood forward. He said Impella, that's kind of like a brand name, but yeah, or a Cheetah, I think they call it a Cheetah too. Impella Cheetah. Or things like ECMO as well, that could be another one. ECMO, take the blood out, oxygenate it, put the blood back in, allow it to oxygenate the body like it should. Basically, giving my heart a rest, giving my heart a break, getting it through the initial injury or the initial shock, let it recover, strengthen back up, and supporting it through this, okay? Pulmonary wise, he said position therapy, so even if they're not ventilated, we can still encourage pruning as well, even if they're on like a BiPAP or an air life mask. But we have airway managers as well, we can do mechanical ventilation. And there's several options out there, non-invasive wise. So you have your OptiFlows, you have your high flow, you have your Vapotherm, your BiPAP. Increasing that oxygenation, increasing that ventilation, helping overall with that perfusion. How do I help my kidneys? Dialysis, right? Good. Neuro support is going to be focusing mostly on seizure management, managing my ICP levels. If I have severe neurodysfunction, remember I have temperature dysregulation as well, so I'm going to provide support for that. If I have severe neurodeficit, it's also going to affect the way I breathe, my ventilation, so I might have some irregular respirations, irregular ventilation, so I may need to provide support ventilation-wise as well. And with that, that can cause some metabolic dysfunction as well, so I may need to provide electrolyte replacements, but also like bicarb, trying to get my metabolic state back in check, back in line. So my blood gas levels are gonna be a little out of whack as well. Again, very close to septic workup, the management of sepsis. Overall, this is a pretty big deal for most families. It's a big change, a critical moment, a lot of stress that's happening. Y'all have all been through the ICU and watched these families come in and deal with this stress. So big roles for us as nurses is gonna be patient and family education. There's a lot that's happening in these rooms. There's a lot of equipment that's hooked up to their family member. These patients are really sick, they're really critical. We've gotta educate our family members on what's going on overall. We gotta educate them on how this is occurring, the path up behind it. We gotta simplify it for them a little bit. What kind of support they need, so that ECMO machine that's beeping over there, what's that helping or what's that doing for my patient? Why are they on the ventilator? Why do I have to do that? Why are they laying on their belly? They're gonna have lots of questions. And you're gonna talk about those short and long-term goals as well. That short temporary management. What is the initial thing that I'm gonna do for my patient? How am I gonna get them through the initial phase of care? And then the longer term goals. Returning back to that activities of daily living, back to their basic functioning as possible. If they're not able to, do they have a trach and peg maybe? Or are they not able to perform certain ADLs? How can they get the proper resources or management for those types of things to help out in those situations? So education, emotional, mental support, comfort support, all those things is gonna be the biggest role that we have in this MODS workup. Other things is your nutrition support. That's really gonna relate to dietary as well. You're gonna coordinate with them. And they're going to assess, see what kind of calorie intake they need, what type of tube feeding they might need, getting them back to appropriate nutrition. Question about mods? No? Okay. Let's talk about epiglottitis. So you have your epiglottis. Remember, that's the little flap that covers your airway as you swallow. So when you swallow, all those bits and pieces do not go into your airway, they go into your esophagus instead. So it's that little flap. With that, I have itis at the end, so inflammation of your epiglottis. That's what we're referring to here. Also, the nearby structures as well, you have the throat, you have the base of the tongue, you have parts of your uvula as well, your soft palate. All of that's gonna be involved when we're talking about your epiglottitis. It's a mouthful to say. Number one cause, infectious, bacterial versus viral. The most common cause is your Haemophilus influenza type B. So that's basically your number one cause there. You have other things like trauma, swelling, edema to that area. Maybe some type of anaphylactic response as well. Assessment wise, I would star or highlight these couple right through here. Hoarseness, stridor. So stridor is what? Everybody be quiet, go ahead, Sam.
Yeah.
Okay, so that
Well, you know, a
little
little bit uglier than that.
bit, a little earlier than that. So that high pitched wheeze, right? You can hear that narrowing of that airway. As they're inhaling and exhaling, you can hear it. You don't even have to put your stethoscope on them, you can kind of hear it from the door. So hoarseness, stridor, I would also highlight drooling and dysphagia as well. That's kind of your hallmark, key, classic signs. Treatment wise, it's in red, it must be important, right? Initially, if I'm suspecting epiglottitis, I say it different every time, I'm not gonna manipulate my airway. I'm not going to stick a tongue depressor back there or a cotton swab back there to look and assess that airway. If I do, I could potentially cause a more severe state or reaction, causing that inflammation and the epiglottis to move further, completely closing off my airway. So until I get a secure airway or an advanced airway that I know is secure, that's when I can start to do my assessment tools. So really, it's gonna be based off of kind of symptom presentation. I'm not initially going to assess or manipulate that airway because I don't want to cut off my airway, but I'm gonna treat first. Heavy antibiotics, airway management, steroids, decrease that inflammation. At that point, then I can continue to assess, okay? Other things, just simple oxygenation, maybe some humidification. Decrease that anxiety as much as possible. They're not overworking themselves, not hyperventilating. If all else fails and that airway closes off, I can also perform an emergency trach, right? Okay. Just another visual picture. that shows you kind of the basic symptoms of epiglottitis. Remember, it's the inflammation of your epiglottis causing a reduction in my airway, closing off that airway, potentially closing it off altogether. With that, I'm gonna have increased anxiety, increased stress, overworking of my breathing, my respirations. So I might have some of that contractions of my muscles trying to get that adequate oxygen in. So that's what this slide is. Big things: hoarseness, stridor, drooling, and dysphagia. Do not assess or manipulate the airway until I know it's secure. If I don't know it's secure and I manipulate that airway further, I can potentially clog off my airway altogether. Okay? And that is it. Okay? So if I was studying, would you study a lot about epiglottitis?
Yes. Four things.
Probably not, right? Okay. Same with mods. It's short and sweet, but there's a few key things to pick out from there.
2 organs,
2 or more organs, right?
that should be a textbook.
We're fixing to write the test right now.
Oh, well, come on. You always ask to help me with some cool questions.
All right, y'all wanna take a break real quick?